Good morning, everyone. And thank you, Andrew. And before I take us through the messaging research project, I want to give a big thanks to you and to Anna Goslin for the opportunity to join you in this work. It's touched me personally and professionally, and I'm very grateful for that. I also want to thank the Cape Cod healthcare team and Tina Soares in particular. I don't see her now. Oh, there she is. For inviting me to be here this morning as well, but also for Tina's input throughout a lot of the stages in this process of research and messaging. So I'm excited to take you behind the scenes of the journey that we went through in terms of learning and finding clarity that led us to research-based language that we believe can really motivate people to have meaningful conversations and engage in advanced care planning in the way that we just heard. We structured the project based on a series of interrelated components that had consumer research at the core, as well as input from coalition members. So I'm going to first review the quantitative research that helped inform the qualitative and the message development work that we did. So I have a lot to cover, and I'll try to do that in 30 minutes. So we had three primary objectives, and this is building on the work that Andrew just described, but it was really to encourage thought, conversation, and action toward advanced care planning by developing unifying messaging that could move those actions and those conversations upstream so that we would make them more about goals and preferences and shared decision making and not about DNRs and pull the plugs and end of life. It was also important for us to deploy rigorous methodology so that the quantitative and the qualitative research could, A, help us get under the surface of the consumer population to identify groups of people who shared some common attributes and some common characteristics, and then group them into what we call in marketing consumer segments. And then B, to be able to develop language that would have universal appeal for all consumers, but also in particular for the different segments. So we accomplished these objectives following best practices in social norms marketing, which I'll talk about in a moment, as well as the principles of social norms marketing. We began the survey research by launching a national survey with a sample of 2,500 adults and 500 Massachusetts as an oversample. And while we used the survey to identify demographic data, it was a real important goal for us to design a survey that included as many variables as possible that we had reason to believe would influence people's willingness or not to engage in advanced care planning. And some of those variables were their experiences as a caregiver, their confidence in their own ability to navigate the healthcare system and manage their own health, their views and feelings about the healthcare system, their personalities, the importance of religion in their life, and their own health conditions. So while demographics are really important and certainly a very important part of this work, this kind of segmentation is about grouping people based on their attitudes, their beliefs, their behaviors, what matters to them, and looking at their personalities, allowing us to really get a deeper understanding of why people engage or not in advanced care planning that can help us then develop the language that will motivate them to take action. So I'm going to introduce you to our 5 consumer segments. They're from left to right. I'm going to start describing them. We explored different ways of clustering people together, and we found that the first most important split was between action takers and non-action takers. Action takers are the first 2 groups that we identified as people who had completed both their healthcare proxy and documented their wishes. And we're not saying that these are the behaviors that we're driving to. It just became very clear that the people who had done both were very different from the people who had not. But the action takers are also very different among themselves, and I'll explain that in a moment. And then we had 3 other segments that we identified as the non-action takers. None of them have completed both of their documents, but that's where their similarities end. So first up is the worried action taker. This is one of our younger segments. Worried action takers often had recent experience with an ailing or a dying loved ones whose wishes were not followed very well and their end of life was not a positive experience. And perhaps this is what motivated them to engage in advanced care planning. This group also has a fairly favorable opinion of the healthcare system and trust in doctors, and they're more likely to favor quantity of life over quality of life. They also report high levels of disability, but they also self-report as having good health. And this segment considers religion very important in their lives, and it also features a higher proportion of Black and Hispanics than all the other segments. Next are our self-assured action takers. And they've checked advanced care planning off their list, and they're pretty confident about it. They did it, they're done. They filled out the documents. Why think about it again? They're much less worried about cost or that their wishes are not going to be followed, perhaps because many of them had experiences of loved ones dying recently, and those experiences were positive. They went very well. And most of the cases were because people had documented or had had conversations beforehand. They're very engaged in their health care, and they show the strongest preferences for quality of life over quantity. This is our oldest and widest segment, and it has about half of them are retired, and many have adult children. So the next three segments are our non-action takers. And again, this doesn't mean that they have taken no action. It just means that they haven't completed both documents. Some of them have had conversations, but not all. In the middle here are the disengaged warriors. This is the largest of our 5 segments. And these are consumers that are fraught with worries and concerns. And despite their doubts about their wishes being followed, and the fact that many of them said that their dying loved ones' wishes were not followed very well, they're full of reasons for not engaging in advanced care planning. They have too many things to worry about. They don't know where to start. They are also too busy. They just don't want to think about this. They're also the least likely to have engaged in conversations with loved ones, because this is also a group that reports that they're most likely to not have loved ones to talk to. These consumers are also not very engaged in their health care and are less confident in their ability to navigate the health system. And they're also relatively more likely to report poor health. This is our youngest and most diverse and lowest income segment than most of the other segments. And they're also least likely to say that religion is important. Next up are the confident independents. And these are consumers who are very confident in their decision to not engage in advanced care planning because their loved ones know what they want. So they share a lot of healthcare views and experiences with our self-assured action takers. They have few worries about serious illness, mostly good experiences with loved ones dying, and a real high confidence in their own ability to manage their health and navigate the health system. They also tend to be somewhat older, mostly 45 and up, typically with adult children. They're also pretty average in terms of racial diversity, income, and education and religion. And last are the self-reliant skeptics. This segment tends to be middle-aged, and they have lower education and income levels, and not unlike our disengaged warriors, but they're kind of the grown-up version of the disengaged warrior. And with that age and experience, they also seem to have lost confidence in the healthcare system. And they're also least trusting of doctors. And like our disengaged warriors, they're also less confident in their abilities to navigate the healthcare system and manage their health. This is the least religious of our groups, and it's more likely to skew female. Self-reliant skeptics are very worried about the future potential illness, about affording care, about their wishes being followed, and yet despite of all of that, they haven't fully engaged in advanced care planning. So our analysis of these 5 segments showed that attitudes and actions, or lack thereof, around advanced care planning tend to cut across demographic groups more so than being defined by them. And I'll just give a personal example. I'm Latina, and I identify as a self-assured action taker. My sister, who's 2 years older than me, is a confident independent. So just because we're Latinas and from the same family, it doesn't mean that we're the same people attitudinally. So that's what we're getting at with this segmentation. And I'll show that a little bit in more detail in this chart, where we have 2 charts, one based on race and one based on age. And as you can see, there are African American consumers in all of the different segments, but they're overrepresented in 2, in the worried action takers and in the disengaged warriors. But as I mentioned a couple minutes ago, they're very different people attitudinally. The worried action takers have high regard of the healthcare system. The disengaged warriors don't. The worried action takers feel pretty confident about managing their health. The disengaged warriors do not. And on the other chart, you can see the retired population, and about half of them are in the self-assured action taker category, but they're still in the other segments as well. So the point here is that when we segment people based on their experiences, attitudes, and beliefs, we get a better understanding of what matters to them, how they think, and what kind of language we can create that's really going to motivate them and move them to action that otherwise could be buried if we're just looking at people based on their demographic categories. So I'm going to move on to message development. And survey data can only tell us so much. And as we know, we really needed to understand the consumer segments. We needed to understand them as human beings, as real people with real lives. And so we conducted in-depth qualitative research to get to that outcome. So I'm going to describe that. But before I do, I want to share with you the framework that we used to create this kind of public health change. And it's a similar framework that's been used in tobacco, in seatbelt use, drunk driving, and it's called social norms marketing. We're all here because we're trying to create a new social norm. And social norm marketing applies principles of commercial marketing to change public health behavior. And it has 4 key pillars. There's the product, and that is the behavior that we're trying to promote, the behavior we're trying to change. In our case, is to motivate people to have those meaningful conversations and then to do the necessary documentation. We know, as you all know, that having the documentation is not as effective if the conversations haven't happened. But there's a price. People have to pay a price to adopt this product that we're selling, quote unquote, and that is overcoming whatever barriers and challenges they may have. What we learned through the research is that while people believe that advanced care planning is important, they're stuck in a thick place of inertia. And that's because they believe their loved ones know what they want, they have too many things to worry about, or they just don't want to talk about death. Then there's the third pillar, and that is essentially all of you here in the room, and that's the pillar of place. Place, it represents all of the different ways that we can engage with consumers in a variety of settings, and you all represent different disciplines in different sectors. All of those sectors, all those disciplines are the places where we can engage with our target audiences. And then last is promotion, and it's essentially the messages we use to persuade people that our product is worth the price. And this is basically what we say and how we say it. So I'm going to zoom in now on the messaging. This message map here, I'm showing it to you because I'm going to refer back to it a little bit later, but this is a helpful tool that we use to construct messaging. And it starts with what we call the umbrella message that's built around a shared value, a belief that most consumers share that can help motivate people to action in a positive way. The umbrella message is then supported by key messages that provide additional reasons to believe, and then that is supported by additional proof points. So I'll show you how this builds out later around advanced care planning. So you heard me say that we wanted to get to know consumers as human beings. So we recruited 150 participants to join us in online community research, and essentially we recruited them to represent the 5 consumer segments that I just described. They also represented a mix of age, race, and education levels, household incomes. About 30% of them were from Massachusetts, the rest from other states. We had about 20% of people who self-identified as having a disability, and 20% who said they have or have had a serious illness, and there was some overlap between these 2 groups. For recruitment, we used a questionnaire that was derived from an algorithm from the survey data that allowed us to identify people and tag them according to each one of the segments. So when we engaged them in activities, we could see what segments they represented. And I'll say that all of these 150 people were very committed. They really opened up. They shared a lot about their fears, their goals, their aspirations. They felt it was a transformative experience because it also motivated them to take action. Some of them had never even thought of this issue, and as a result of being part of the communities, they were starting to have conversations with their family, with loved ones, with friends. So this is an image that shows you the environment in which we engaged them. This was all online, and on a daily basis, we were interacting with them over that 4-week period. So I'm going to review now how we developed the language with the input of these 150 highly committed and passionate individuals. So I'll start with the shared value. And central to the social norms marketing strategy, and in order to build and create an umbrella message, we needed to identify a shared value that would resonate with most people. And having clarity around a shared value is important because it informs the language choices that we make. And through the research and conversations with coalition members, we identified 3 shared values that helped us reframe advanced care planning. So it's more about our values, preferences, and goals, and less about life-sustaining treatment and death. And that it's more about high quality and meaningful conversations and less so about documentation or the process of documenting. So the 3 shared values what we identified were, the first is self-determination, and we expressed it as, I want to have power to make my own life choices. The second is quality of life, which we articulated as, I want to live a good quality of life my whole life. And then self-advocacy, I want care that treats me as a whole person, not just a disease. So leading up to the testing of these shared values, we had engaged participants in discussion about what constitutes quality of life for them and how they see that as they age and the importance of having conversations. We didn't refer to it as advanced care planning because it wasn't a term that was familiar to most people. We also asked them to tell us about their experiences with health care professionals and also their experiences in general around healthcare. So this upfront exploration gave us some grounding so that when we asked them to react to these shared values, they weren't doing it in a vacuum. So what we learned from the testing of these shared values was that people really preferred the shared value of living a good quality of life. It was the one that resonated with most participants. But it wasn't because the other 2 were not important. They saw having power and control over decisions that impact their lives also as very important shared values, but their bigger aspiration was to live a good quality of life their whole life. And when we first engaged them in these discussions, we asked them what constituted a good quality of life. And for many, the answer centered around their independence. And that was to be able to live on their own, move on their own, and be on their own. So quality of life was important, but it referred to this need to be independent. And I'm going to come back to this in a moment. We also learned that there was a noticeable contingent of participants that did not have loved ones, that were estranged from family. And for this group, the self-determination, the power shared value resonated the most, but they also recognized that they needed to live a good quality of life because they believed that they're going to have to rely on themselves to take care of themselves if they become seriously ill. What's important to note about this group is that language and messaging that was centered around loved ones did not resonate because loved ones equals family. And this will come up when I review the messaging, so keep that in mind. So as we dug into people's responses, we surfaced 3 key insights that I'm going to share with you. First is that living a good quality of life is what consumers expect. I said that. But that having control and power over the decisions that impact their lives is how they see attaining the quality of life that they envision for themselves. So the why is quality of life, the how is the power and control. Second, at first when we started talking about quality of life associated with serious illness, it immediately put them in the mental traps of DNRs and plugs, and pull the plug. And no matter how hard we tried, it always went to that place. But as we started to probe further and we started to ask more questions, and we asked them things about what matters to them, what does a good day look like, we started to see a shift in their associations and their responses to the kinds of answers that we are all talking about. And these were in the realm of making good memories, being treated with respect, having some degree of mobility, even if it meant reading fiction, making peace with God, repairing family ties. And for one participant, it was her daily smoothies. That's what really mattered to her. Why not, right? So while not everyone had loved ones, they did have people who mattered in their lives. They had friends, they had clergy, they had clinicians. And so that was an important finding for us because they rejected any messaging that was centered around loved ones. We also, on the other hand, learned that people who had loved ones had not done anything because their loved ones would know what they want. So informed by these findings and these insights, we proceeded to develop the umbrella campaign or an umbrella message. And think of the umbrella campaign as the visual, as the thematic glue that you see that creates awareness. It's kind of what tobacco did, what marriage equality did. It's those visuals, those messages that you see in many different places that start creating awareness and understanding for our cause. So in developing the umbrella campaign, and I'm going to show you the examples that we tested, we made 6 strategic decisions. The first was to restate quality of life into an easily understood and concrete image that people could actually relate to, and that could help move them away from the mental traps of DNRs and pull the plugs when associated with serious illness. And for example, we use the words good days. You know, what does a good day feel like, look like? I think we can all answer that question. Quality of life is somewhat abstract. Then we also had to normalize what it means to have the conversation. At first, people found the term conversation somewhat daunting and off-putting, something too serious. And so we used language like a good talk. And we can all imagine what a good talk sounds like, feels like. We also had to be inclusive by using language like people who matter most, because some folks did not have loved ones. We did not want to include the language loved ones. And for those who had loved ones, we wanted to create the doubt and ask the question, if you became seriously ill, would the people who matter most really know what matters most to you? We also had to recognize that people want to have control and power. And so we use language like share the kind of care that's right for you. We also had to make it relevant to their current life circumstances by making it about today and no matter what happens tomorrow. And we also had to be aspirational to draw people in, because when we first started talking about serious illness and quality of life and conversations, some people turned away because it was not something relevant to them, because 1, they were healthy, or 2, they were young, or they just didn't feel like they wanted to talk about serious illness. So while everything you'll see is about serious illness, it's not the main headline in the posters, because our understanding was that if we did that, people would tune us out. So we tested 3 campaigns. These are drafts, and I'm going to show you these. And we exposed the community participants to posters that depicted the messaging that I just described for you. And we asked them to highlight on these posters what resonated and what did not resonate, both in language and visually. And then we asked them to pick the one that they thought would inspire them the most and the least to have conversations. So by far, the Good Days Start with Good Talk campaign resonated with most participants, and it was because they found it warm, cheerful. It conveyed a sense of togetherness. The fact that we had a couple of people in the images made them feel like this was about something you do together. You don't have to do it by yourself. It was straightforward and easy to remember. And I'm going to read what one participant said. It's a great slogan that draws me in, and it focuses on the importance of highlighting good days, what they mean to you, how you want to have them if your health declines, and so on. Very relevant, but still positive. It's not just saying, well, you're going to die or be severely disabled. What do you want to do with yourself? And it's not just a generic have a conversation thing, which is really too generic to be meaningful. So these were the kinds of feedbacks that we were getting. But on the other hand, we had another participant who said, when you're ill, it's hard to find a good day to talk. So all of this input was very valuable to us as we continued to refine and test language. The What's Best for Me campaign ranked in second, and it was because people found it somewhat vague and hard to make the connection to serious illness. But those who liked this campaign liked it because it gave them examples of what quality of life could be, and it got the ball rolling in their mind of what their own version could be. And then Get in the Conversation ranked in third because of just having one person in the image. People felt like it was not conveying that sense of togetherness. And so only those who felt like they were really empowered and in charge of their health care liked this campaign. So after testing the campaigns in the spring, we continued to refine them and revise them. And in the summer, in August, we tested again with a new set of consumers and got to a place where we identified what would make the most sense in terms of a campaign and what would be most effective. So we're currently in the process of working through updating the campaign and putting together a toolkit of materials that will be available also on the Coalition website. So I'm going to now move on to messaging. And this is the second part of what we did with the online communities. And I know this slide is pretty text heavy, but we did want to share it with you so you get a sense of what kind of language we tested. Leading up to the online communities, we had engaged in conversations with coalition members, and this is where Tina was also provided great input, as to what are the reasons that you hear most often people engage in advanced care planning. So we used those reasons to construct language that we then tested with participants. Those 5 reasons were love and gift, that doing ACP is a gift that you do for your loved ones. Peace of mind, that there's no need to wander, and that engaging in advanced care planning gives you a sense of relief. Power, expressed as we can have a say in our care, that around the notion of having the right to demand the health care that's right for you. Control, and that was expressed as conversations clarify. But here I do want to mention that when we talk about control, we're not talking about having control over your health outcomes, but rather having control over the people you choose to make decisions on your behalf, or the kinds of decisions that you want them to make for yourself. And then the last was honor loved ones' wishes, which is about activating the conversation in others and making it okay to ask your loved ones about their wishes. So we wrote language for each one of these reasons, and we presented them also with proof points. And here you can see an example of what participants were looking at. We shared all 5 reasons one at a time, and we explained to them that this language could be seen on websites, on marketing materials, on posters, that this would be language that could be used in many different settings. And we asked them to really focus on the words, to highlight what resonated, what did not resonate. And then that gave us an opportunity to really understand the nuance in language and where we had some traps that we had to overcome. So this shows you an example of one of the exercises, and it's a visual output. And it shows like a word cloud where people put emphasis on words that resonated and words that did not resonate. So we took all of this. There was a ton of output that we reviewed and really combed through that to identify what are the key findings and also what are the changes we need to make to the language. So what we learned is that word choices matter, and this exercise helped us identify the verbal landmines. And some of those landmines are around the word right. People rejected the use of the word right because it put them in a defensive mindset. It made them think that they had to fight for their health care, and that's not what they want. For some, conversations can be daunting when it's associated with serious illness as a main message. And so a good talk was more of an approachable way to enter the conversation with them. Honest conversation can feel judgmental, while an open conversation does not introduce judgment. There's a very slight difference between honest and open. Comparing advanced care planning with wellness, overall, like the wellness movement, or comparing it to something you do like you have an annual checkup, was also rejected because it didn't feel realistic. And healthcare consumer was something that people reacted negatively to. They pushed back on that because they don't see themselves as consuming care. And I know I'm talking about consumers, but that's because I'm a marketing person. But the final language that we created does not use the term consumer. And then certain concepts that are typically used in advanced care planning did not resonate. The concept of peace of mind, that doing advanced care planning provides a sense of relief, didn't really work. People didn't feel like it was believable, and for some, it was also exclusionary of people with low-income households, because not everyone can afford to follow your loved one's wishes if you don't have the financial means to do so. And then the concept of lessen or ease the burden didn't work as well. And it was also because people felt like having a conversation will not take the burden of having a family member or a loved one living with a serious illness, and also that it shouldn't be a burden to care for someone if they have a serious illness. So these two concepts are concepts that we did not make, that did not make the final cut in terms of the language that we provided. So after we asked participants to read all of the reasons and highlight what worked and what didn't work, we asked them to look at them again and then to rank them and tell us which one of those reasons resonated with them the most and would motivate them to have a conversation. So this chart shows you all the 5 reasons, all the 5 consumer segments. And what we can see here is the power and control were the messages that resonated the most. Control being conversations clarify, and power being we can have a say in our care. And I should add that participants who have or have had a serious illness preferred conversations clarify. They like the idea of a message about control. For those who self-identify with disability, they also preferred conversations clarify. But they also preferred we can have a say in our care. And for in terms of race and ethnicity, African American participants preferred we can have a say in our care, and Latinos preferred conversations clarify, and caring means learning what matters to them. And Asian participants also preferred conversations clarify. So in sum, the control and power messages were the ones that resonated across the board, regardless of consumer segment, race, ethnicity, health status, and age. So remember the umbrella map I showed you right at the beginning? This is the way we started to construct the language. And here you can see the umbrella message. I'm not going to read what it says. Hopefully you can see it. But it's really using those keywords that I just mentioned. And what's up on the screen is what came out of the process of reviewing this language with participants. We included the 2 reasons or supporting messages that resonated across the board, and proof points that can continue to emphasize the reasons why you should engage. This is the kind of language that would resonate across all different groups of people. And this is the language that we are recommending can be applied in settings where you have groups like this that you don't know who's an action taker, who's a non-action taker. But it creates that sense of common ground. Here is the language fully fleshed out, and I don't expect that you can read this, but this is currently available on the Coalition's website as part of the research that we conducted in the spring. Like I said earlier, we're in the process of pulling this all together into a toolkit with language, with creative, with visuals that can be used and adapted. The language is created in a way that's modular, so you can pick parts of the language that makes the most sense given your circumstances and your needs. So this is coming soon, the final toolkit, and hopefully in the next month or so, right? And I hope that with this shared understanding of the learnings from the research, the insights that emerge, and the language that resulted from this process, that you leave here today with an expanded view of how to think about language in a way that motivates people to have these conversations and motivates both the people who are healthy and the people who are living with a serious illness. And I'm going to quote you, Andrew, because I think you say it great. We can help change the frame of advanced care planning so that it's about what matters most to people, about quality of life and empathy and compassion. So thank you very much.